I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the Q&A box. We'll see your questions and we'll do our best to answer them by replying to you in the Q&A box or out loud during the last several minutes of the webinar. For those of you in attendance who are health professionals, we are glad that you've joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Christian Mende. Dr. Mende is a clinical professor of medicine at the University of California, San Diego. Dr. Mende graduated magna cum laude from the University of Heidelberg School of Medicine in Germany. He then completed internships and residencies at County Hospital in Sanderbusch, Germany, and Tucson Medical Education Program in Tucson, Arizona. Dr. Mende's postdoctoral training includes a National Institutes of Health Fellowship in Nephrology at Peter Bent Brigham Hospital and Harvard Medical School in Boston, Massachusetts. Dr. Mende is board certified in nephrology, internal medicine, geriatrics, and clinical hypertension. Among his medical affiliations, Dr. Mende is a fellow of the American College of Physicians, American Heart Association, American College of Nutrition, American Society of Nephrology, and the International Society of Nephrology. In addition, he is also a fellow and charter member of the American Society of Hypertension. Dr. Mende is a reviewer for several medical journals and is widely published. He has made contributions to the medical press on experimental and clinical renal disease, hypertension, diabetes, and various other medical topics. Thank you, Dr. Mende, for joining us. I'll now turn the presentation over to you.
Well, good afternoon, and thank you, Molly, for the introduction. It is my pleasure to present the objectives to you, which are diabetic kidney disease. So we'll talk about signs and symptoms, and importantly, how we can prevent diabetic kidney disease. And exciting new treatment options are now available in the last 2 years for diabetic kidney disease. Next slide, please. So this is the introduction. Next slide. Diabetic kidney disease, or we call it DKD, actually is chronic kidney disease, which you may have heard before, or CKD in the diabetic. We now prefer to call diabetic kidney disease DKD because that means that the kidney disease is caused by the diabetes. And the number one cause, and you wouldn't develop ever diabetic kidney disease unless you have uncontrolled high blood sugar levels, which we call hyperglycemia. And and you're probably also aware of, this can affect multiple organ systems. One of them we'll talk about today are the kidneys. We know that it involves the heart, from the heart failure standpoint, as well as the coronary arteries, the eyes, and the nervous system. So on the right-hand side, there is a very complex chart. Again, this would be a lecture by itself. So importantly, if you do have type 2 diabetes, about 30% of the people with type 2 diabetes at one time in their lifetime in the US today will develop some sign or type of diabetic kidney disease. So that's almost 1 out of 2. Next slide. So when does a healthcare provider or doctor diagnose with diabetic kidney disease? So there are 2 criteria. So either one applies. So first, importantly, from a blood test, which is called creatinine, which is drawn when you have your blood test done, you can calculate, and this should be provided by a healthcare provider, your estimated glomerular filtration rate. So the EGFR is the best test we can look at how well is your kidney performing. And if the EGFR is below 60 ml, that means it's below 60%, you would then have a diagnosis of diabetic kidney disease if this is not just present once, but it's present for 3 months or longer. So this is the one diagnosis. But even if your EGFR would be 80 or 90 and you have perfect renal function, you would still have diabetic kidney disease if you develop albumin in the urine, which also can be called proteinuria or protein in the urine. And this is measured by a simple urine test in the office. And if it's over 30, then per milligram per gram, so the number to remember is 30. So either one of the two, in many instances, both being abnormal, being albumin and the EGFR less than 60, are used to diagnose diabetic kidney disease. If you look at records and you talk to people with type 2 diabetes, which I do frequently, is only about half of them know that they have diabetic kidney disease. So one of the things I want you to know, you usually know your cholesterol level, you know your LDL. Very often you also know the numbers of your blood pressure. I want you as a diabetic to remember three other things and ask for it. You ask your physician, what is my EGFR? What is my kidney function? And also, do I have albumin in the urine? And the third one we'll see in a moment is, what is my A1C? So these are the three key questions which are important, because as a diabetic, it is teamwork. It is you and your healthcare team providing hopefully the best care, and you should be aware of and you should know your numbers. I think that's very important from now on for you, as you will see in this presentation. Next slide. So diabetic kidney disease is often silent. So it is important to know the early abnormalities. So you will know about the EGFR albumin when you have no symptoms whatsoever. So unless you go below 40% of your kidney function, you may have no symptoms whatsoever. You can have large amounts of albumin in the urine, and it may foam, and you may not even pay attention to it, and you're not aware of it. So if it's become more severe, when it's less than 40%, then you can be having fatigue because you're anemic. You also may have some muscle weakness because the potassium levels are elevated, or you may develop swelling in your legs or in your hands or eyes when you wake up in the morning, which we call edema, secondary to fluid retention. And if you don't have already high blood pressure to start with, it may suddenly get much worse or more difficult to control. Later on, you may have a loss of appetite and weight loss. And by the time you develop a metallic taste, which is not unique to diabetic kidney disease, you can have a metallic taste because you're refluxing or for certain foods you take. So this is not unique, but it can be a sign of late diabetic kidney disease. Next slide, please. So what other factors are risk factors for you to develop diabetic kidney disease besides hyperglycemia, which we'll address in a moment? Very important is hypertension. So if your blood pressure is above 140 and your glucose is not very well controlled, then you have two major risk factors to develop diabetic kidney disease. So this is very important, hypertension. Second is obesity. So how do you know you're obese? Well, you ask your healthcare provider when they check your weight, what your BMI is, your body mass index. So a BMI of 30 or above, it calculated for you by your healthcare provider, means you're obese. And a BMI of 25 to 30 or 29.9 means you're overweight. So an ideal weight is 25 or less. So why is obesity so important? Because obesity without high blood pressure and without diabetes has a 3 times higher risk of developing kidney disease than a person which is of normal weight. So we see with the increased obesity in the United States, not just more people with diabetes, we also see more people with reduced renal function. Now, elevated cholesterol and elevated triglycerides are contributing factors, but they're more important to preventing heart attacks and strokes. And their uh, importance for the kidney is less. It's not unimportant, but it's less. Again, if you have a tendency or already early diabetic kidney disease, avoid high protein diets. So a high protein diet is 1.2 gram of a protein per kilogram per day. So 1 kilogram is 2.2 pounds. So you can divide your pounds by two, and let's say you're 150 pounds, you divide it by two, that's 75 pounds, and then minus 10%, which is 7.5. That would make you about 67.5 or 68 kilos. So you should not be eating more than about 65 grams of protein, 0.8. It will show you this in a moment. So a high protein diet actually makes the kidney work overtime. So that is one of the reasons we don't like very high protein diets, particularly not if you have diabetes. So the last two, well, you can do something about smoking. If you already have albuminuria and you smoke, it gets worse. I've seen people reduce the albumin in the urine by half by just stopping smoking. And the last three things, age, family history, and race, we can't do anything about it. What's important is that if you do have a family history of kidney disease, even if it's not associated with diabetes, or if you have a family member on dialysis or being transplanted, that increases your risks. And we don't know all the reasons why. And then, of course, African Americans, Hispanics, Pacific Islanders, and American Indians do have a higher risk for kidney disease, including diabetes and diabetic kidney disease. Again, that's not very much you and I can do about that. Okay, next slide, please. So let's talk about hyperglycemia on the next slide. So the elevated glucose, not just for 1 day or 1 week or 1 month. So it has to be elevated for fasting glucoses, let's say of 128, 130 and higher. And after meal, you consistently 200 plus. And this is going on for months, and very often it may go on for a year and longer. And that is the sine qua non. What I mean with that is you cannot develop diabetic kidney disease unless you have prolonged, uncontrolled high blood sugar. You can develop chronic kidney disease without diabetes, but the hyperglycemia is the absolute key reason for development diabetic kidney disease. Next slide. And so what can be done? I think you need to work with a healthcare provider. Many of you, at least twice a year, and some more often, get a blood test done, which is called A1C hemoglobin. That measures the last 3 months. It gives you what your average blood sugar is. It actually tests for about 70, 80% more what your sugar was in the last month before the test. But that is an excellent way to assess your long-term sugar control. Again, depending on your diabetes, you may need daily blood sugar testing or every other day or 3 or 4 times a week. And that you need to actually ask your healthcare provider, how often would you like me to have my blood sugar tested? If it's frequent, 2 times or 3 times a day, it becomes a nuisance, but a little bit painful. And you may as well consider and ask for them to provide you with a prescription for what we now call continuous blood sugar monitoring, or CGM. That is a wonderful way for people with difficult to control blood sugars or a tendency to develop severe hypoglycemia, low blood sugars, to know exactly what their sugar is. You can put your cell phone over your monitor, which is placed for weeks, and you know at any time of the day what your sugar levels are. So this technique has been perfected in the last 3 years. But again, all 3 methods, depending on your needs and the suggestions of your healthcare provider are good ways to judge what your blood sugar level is and how well you are controlled. Next slide, please. So ideally, you'll probably already know the number. It should be below 7. That's the A1C level. Again, that needs to be taken into account, whether it's easily achievable and you can reach that level with your medications without developing hyperglycemia. If you already have been diagnosed with diabetic kidney disease, again, you have to ask, what's your EGFR, what's your albumin, and ask him, do I have diabetic kidney disease? So if that's the case, as a nephrologist, I like for your A1C to be lower, less than 6.5. Again, only if I can safely get you there without hyperglycemia. And on the right-hand side, very nicely outpoint, you see that the sweating and the pallor and being irritable. Some people even get angry and annoyed, hungry, maybe sleepy, or lack coordination or thinking. These are signs of hypoglycemia. And you already probably were told what hyperglycemia are. You have a dry mouth, you have increased thirst, you may have headaches or weakness. At times, if it's severe, your vision changes and you can blurred, and almost always you have very frequent urination. You may pass urine every hour or two without having any bladder infections or any other abnormalities, just from the high sugar. Why? Because your kidneys are working overtime, literally. Next slide. So hyperglycemia, how does it affect your kidney? So if your blood sugars are consistently elevated, particularly if they're in the 150s, 160s, and over 200 after a meal, you see the numbers here, they actually lead to an increased blood flow and work in the kidney, which we call the glomerulus, which are the units which are filtering the pressure. I'll show you a diagram in a moment. And importantly, you're not only making the kidney work higher, so your kidney function percentage-wise goes from 100 to 120, 130, 140%, but you're also increasing the pressure in the kidney. So it's very similar to the pressure in your arm, let's say, which is 130 over 80. The pressure in your kidney normally is much lower, like let's say 65, 70. But if you hyperfiltrate because your glucose is elevated, the pressure in the kidney goes up. And the kidney is not well equipped to handle high pressure in the kidney. So then it becomes damaged. The filter becomes more porous. And you not only lose kidney function, but you also lose albumin, the urine, as the next slide will show you. Next slide, please. And this is the diagram on the left. It shows that the filter, which is like a sieve with very tiny pores, doesn't allow blood to go through. So otherwise you would have blood in the urine. So the urine is of yellow color. It is not bloody. And it also doesn't allow you normally to have albumin or globulins or cholesterol and other components of your blood to appear in the urine. So you filter water and you filter potassium and sodium and salt and metabolites and toxic waste products, but you don't filter solid components of your blood unless you have a damaged filter. The pore size gets bigger, and now you can have albumin go through, and then you have albuminuria, and that is a sign of kidney disease in the diabetic and also actually in the non-diabetic if it's over 30. Next slide, please. So albuminuria, as we call it, albumin in urine, also proteinuria, has two important implications. First, it can get from 30 to 300 and 3,000. And the higher it gets, the more albumin you excrete, it becomes actually toxic to the kidney. So you not only filter the albumin, but some of it gets reabsorbed by the kidney, the tubules further downstream, and then causes scarring of the kidney itself. So you have a dual injury. You have the albumin being filtered, and then subsequently damaging the kidney. But importantly, albumin in the urine is a sign that the lining of your vascular tree, so the lining in your coronary arteries, in your heart, in your brain, which you call endothelium, this lining is also affected when you have albumin excretion in the urine, and can therefore be leading to cardiovascular events. So having albumin puts you at a higher risk at a stroke, a heart attack, and heart failure, and other cardiovascular events such as peripheral arterial disease, where you have issues with circulation to your feet and your toes. So again, remember, an albumin above 30 is abnormal and typically should be told, but you need to ask for it, I think, to get involved, as I mentioned earlier. And the good news is, as I'll show you later on, it can be treated, and in many individuals, it can be made to go back to below 30, meaning you can actually reduce the albumin back to normal. Next slide. So what about prevention and treatment? Next slide. Again, if you have diabetes, try to stay at normal weight. And if you have a risk factor, like a family history or tendency, somebody telling you you have a risk for pre-diabetes or diabetes, try to work on your weight to prevent to become overweight or obese. So one of the best diets, and you don't have to go on a stringent diet, is the Mediterranean diet. I realize because fruits and vegetables are not cheap, but hopefully in the US, you live in an area where you have access to fruits and vegetables on a seasonal basis, and have a very high vegetable and fruit intake, which you can go on the Google or on the internet and look up the Mediterranean diet. And I would encourage you, if you have issues with your weight, to sit down once with a dietitian and get a nice 50 minutes or so discussion. So even if you're overweight and obese, don't give up. And even losing 5 to 7 pounds makes a difference. It makes the difference towards your A1C if you have diabetes, because it makes it easier for you to get control. The medications become more effective. It also lowers your blood pressure when you lose weight. It also makes your cholesterol and triglycerides go down, and it makes your energy level go up. So basically, if you cannot succeed to lose any weight, even 5, 6 pounds, talk to your doctor. There are 5 drugs, 4 of them over the counter, but many of them now are beginning to be covered, and they're not long-term solutions. So I'm not suggesting that you get on a weight-suppressing drug for the rest of your life, but do it for 3 to 4 to 5, 6 months, and it will get you down your weight, and you hopefully can maintain your weight if you cannot just lose weight because your appetite is so ferocious, which is the case in many of us. So weight loss is indeed a very tough task to achieve for all of us. Next slide, please. So if you look at diabetes, so if you have blood tests, your physician may tell you that you have pre-diabetes, because you can do an A1C on anybody, normal or diabetic or not pre-diabetic. And if you're between 5.7 to 6.5, you have a risk of converting to diabetes. This is your unique chance. It takes 5 to 7 years in most people to go from pre-diabetes to diabetes. And there are many patients, by losing weight 10% and exercising, as we'll get into this in a moment, at a low level, 150 minutes a week, that 2/3 of the people in studies in the US and in Europe were able to never develop diabetes, and to either stay at the pre-diabetes level or revert back to normal. So pre-diabetes is not an absolute fate diagnosis saying that if you got pre-diabetes, you're going to have diabetes. There are no drugs approved for pre-diabetes officially by the FDA, the drug agency of the US. However, most of us physicians, I would say almost all, are using one or two medications to prevent prediabetes, in addition to changing of lifestyle, weight loss, and exercise to prevent the prediabetes going on to diabetes. So next slide, please. So what does it take to be physically active? I think all it takes is 30 minutes of exercise 4 to 5 times a week, and you don't have to kill yourself. I mean, you can go out and walk. Now, walking in a mall, like many of my ladies tell me they are doing, they may be doing an hour of walking in a mall, but they stop and go because they look at windows or go into stores, and that's not really count fully. So we like continuous exercise. You can have slow speeds bicycling, 5, 8, 10 miles an hour, swimming, even walking with your dog, which is wonderful, or anything to stay active continuously for 30 minutes, 4 or 5 times a week. And I think what is very important is also do some weightlifting. Again, pick a weight, 2 pounds, 3 pounds, 4 pounds, where you can do exercise 12 reps. If you can pick up a weight and you cannot do 12 reps, the weight is too heavy, don't use it. I rather have you do 15 reps instead of 5 with some heavy weight. So why is it so important? Because after age 40, all of us, me included, lose 1% of our muscle per year. So after 20 years, you lose 20% of your muscle and you replace it with fat. What are muscles doing? Well, not only do they allow you to be, going upstairs and getting out of the chair easy and being physically fit, but they allow you to burn more carbohydrates, that is sugars, even when you're not doing anything. So a higher muscle mass or a maintained muscle mass from doing twice a week resistance training, and again, 30 minutes would be fine. And if you say, well, I'm going to do 2 days a week of exercise training, and I'm going to take Sunday off, and I'm do 3 days a week of walking for 40 minutes, fine. I mean, that would be a wonderful program that you walk 2 days and the third day you do some weight training for 20, 25 minutes. I think it will pay off, and it will actually, if you do have diabetes, it reduces your insulin requirements. If you're on insulin, makes the drugs for diabetes more effective because you're making your insulin more powerful. You're turbocharging your insulin if you exercise, in particular if you do a resistance training. Next slide, please. So what about the diet? I think you already heard this, vegetables, fruits, whole grain, fiber, nuts. I again realized that this is not a cheap program. Unfortunately, processed meats, refined carbohydrates, and all these beverages, which are sweetened, are inexpensive and very tasty. They manage to really tickle our taste buds. And so they should be limited. And specifically, last week, the International Society to Prevent or Treat Diabetic Kidney Disease, DKD, came up with this food group allowance saying ideally 50% of what you eat should be vegetables and fruits and 20% protein. We like more plant protein, which is again in soy and in nuts, and over animal protein. Again, the limit ideally is 0.8 gram per kilogram per weight per day. Just to give you an idea, it's very easy. An ounce of meat or fish or seafood, 1 ounce of cheese are 6 to 8 grams of protein, and 1 egg is 6 to 8 grams of protein. So it's really pretty easy for you to judge how much protein you are taking in. And again, 25% should be whole grains or starchy food, and that includes the breads and the pastas of this world. So one should limit the salt intake to 5,000 milligrams, which is 5 grams. You may be more familiar with sodium, Na, so for natrium, Na is the symbol. So look at the cans you buy for soups or other items. If you buy processed foods, they now have to, by law, have a sodium content on there. So you can see that you should not exceed 2,000 milligrams, which equals 5,000 milligrams of salt or 5 grams of salt a day, because salt will increase your appetite. Actually, we know that now. Salt will increase your blood pressure, and salt has negative implications also for the kidney from that standpoint, and you would retain more water and get potentially fluid retention. So these are all reasons why we are limiting the salt intake. Next slide, please. So what can you do beyond the A1C and the blood sugar control? There are about 12 classes of blood pressure, different drugs. Some of them are very excellent. They're 20 to 30 years old. Almost all of them are now generic, so they cost $4 or $5 a month. And again, like ACE inhibitors or ARBs, angiotensin II receptor blockers, low-dose diuretics, low-dose calcium channel blockers have very few side effects. So your blood pressure should be below 140 or 190. And if you do have hypertension, or splurge and get yourself from one of the major healthcare chains. I don't want to name any, but even your supermarkets have now blood pressure cuffs. They're less than $30. They work very well. You sit down, you take your blood pressure, both feet on the floor, back supported. You discard the first one, and then you wait a minute or two, and you take reading 2 and 3, and that's your blood pressure. So it should be below 140 or 190. It is much more reliable at home than in the office, because many people have much higher pressures in the office because of the situation. We call that white coat syndrome. So if you got albumin in urine, or you have already diabetic kidney disease because your kidney function is less than 60%, I would like your pressure to be less than 130 over 80. We already talked a little bit about LDL. It should be the cholesterol, the bad cholesterol should be below 100. When you have diabetic kidney disease, or you have cardiovascular disease, you have angina or known heart disease, you should be below 70. And many cardiologists now want you to be below 55, which is not that difficult to achieve with the statins and other drugs today. Stopping smoking is an absolute must. And avoid using daily NSAIDs. Now, if you got a headache and you use 1 or 2 NSAIDs once every 7 to 10 days, well, so be it. But from a nephrology standpoint, you cannot afford to renal-wise take 2 NSAIDs a day or more, or 4 or 5 times a week, like the ibuprofen and the other ones over the counter. There are 6 or 7 of them, because they will worsen your kidney function, and they are potentially toxic. They raise your blood pressure, and they have other side effects like retaining of fluids. Also, herbs, you got to check. Some of them are toxic to the kidneys. And when you get antibiotics prescribed, if you have diabetic kidney disease, ask your healthcare provider whether this drug is safe for you to take if you have 50% of kidney function, because many of the antibiotics need to be modified, and the dose needs to be reduced if you have diabetic kidney disease. Again, you need to work with your healthcare provider and ask him anytime you pick up an over-the-counter drug, not for one-time use, but if you use it, 2, 3 times a week or more often. Next slide, please. So what do we have to offer for you? Now, for the last 20 years, we use the ACE inhibitor, just to name a couple of them: lisinopril, captopril, benazepril. They're all generic now, or the ARBs, which are irbesartan or losartan or irbesartan, and they're about 10 on the market. And either one of the two will reduce albuminuria by almost half. So if you are 100, you go to 50. And it will reduce the progression of diabetic kidney disease by 20%. But that means that 80% is still going on. So these drugs are wonderful. They also are used to treat hypertension. So they have been on the market for 20 years. But, by slowing progression by 20%, that is still leaving a lot of room for worsening. So in the last couple of years, another class of drug has been FDA approved for diabetes. And we found out in the last 2 years that they have major benefits to reduce albumin, again by 35 to 40%, and they slow the progression of kidney disease by 35 to 50%. So this is on top of the 20%. So now we're talking about 65, 70 or more percent of slowing. So who are these SGLT2 inhibitors? Well, I'll give you the generic names. There are now 4 on the market, 3 which have been very popular. Empagliflozin, the other one is called dapagliflozin, and the third one is called canagliflozin. So all they call it gliflozin. Just look at your medication, and if you have diabetic kidney disease, as I'll show you in a moment, you should be on one of the SGLT2 inhibitors, irrespective of what else you have. So if you have albuminuria or you got a kidney function below 60%, we now strongly recommend the use of SGLT2 inhibitors in addition to the other drugs you have. You may be on a GLP-1 agonist by injection, which reduce A1C powerfully. People lose weight with them. By the way, the SGLT2 inhibitors also make you lose 5 to 6 pounds. And the GLP-1 agonists, they even make you lose 8, 10, 12 pounds. So the GLP-1 agonists are not FDA approved to preserve kidney function yet. I think there's a good chance maybe in the next year, but they clearly reduce albuminuria. So what are the latest guidelines from last month? From the International Society for Kidney Care to start using metformin and SGLT2 inhibitors in anybody who's not on them if the EGFR, the kidney function, is over 30 ml, that means over 30%. So these 2 drugs are recommended, and then very often one would add an ACE inhibitor or ARB on top of it. So you're on this triple combination of SGLT2 inhibitor, metformin, and an ACE inhibitor or ALB, which should control your blood pressure, your weight, and importantly, reduce albuminuria and progression of renal disease. The next slide, please. So what are the key takeaways I wanted you to know today? That up to a certain high degree, diabetic kidney disease is preventable by correcting or controlling your glucose level, your hypertension, the smoking, the weight, and the what we outlined today. Work with a healthcare provider. Ask him to be tested for urine albumin, and you want to know the test results of it. Get to know your A1C, your urine albumin level, and get to know your EGFR, your kidney function test. I think that to me is very important. And as a nephrologist, my patients all know their 3 numbers. So we can work on them and see the progress we make as we lose weight, control the blood pressure, control the blood sugar, and improve albuminuria. So this is a key aspect, because taking care of diabetes is not just a physician's or healthcare provider's duty, it's teamwork. It is you and me who need to work together. So even if you already know you have diabetic kidney disease, you can now take important steps, as I hope you understood from the presentation, to slow its progression majorly and make a great impact on your quality of life. So again, the treatment options are available, and you again can get to the American Kidney Foundation for more information, or ask your physicians, or Google diabetic kidney disease, DKD, or CKD in diabetes to get more options to understand the mechanism and the benefits derived from treatment. Next slide, please. So at this point, I am very happy to answer questions, and thank you for taking your time to listen to the presentation.
And thank you, Dr. Mende, for leading such an excellent webinar this afternoon. So at this time, I'd like to ask you a number of questions that we received from our audience over the course of the webinar. So our first question is alcohol consumption a risk factor for diabetic kidney disease?
Yeah, very smart question. You know, alcohol is probably the only organ I know where you, if you really drink a lot, okay, let's say you don't have diabetes, and let's say if we use the word, you have alcoholism. Well, you get all kinds of diseases, liver disease and other diseases and heart disease. But the kidney per se doesn't get damaged very much unless you develop severe liver disease or heart disease. But the alcohol is pretty inert. Now, what the issue with the alcohol is, it's the calories. One gram of alcohol. So 1 gram is 1/30th of an ounce. So let's just see, 1 gram of alcohol is 7.5 calories. So let's just see you have a glass of wine. Okay, that's 150 calories. You drink a small can of beer, 150 calories. Well, if you use light beer, it's down to 90 calories. You're short 60 calories. So basically, my concern about the alcohol is 80 calories, and there's no question. If you have a blood sugar of 110 and you drink a glass of wine with diabetes, the blood sugar is going to go up very quickly. I always tell my patients, remember that race cars don't use regular gasoline. They use gasoline with a lot of alcohol in it. So that happens to us too. It's just, you're becoming a race car and your glucose goes up. And so that's why we should dramatically reduce the alcohol for the calories in, because it raises blood sugar.
That's a great metaphor. I'll definitely keep that one in mind. Someone else asked, I heard that muscle activity, such as when you exercise, releases acid, thus increasing the load on your kidneys. Is this true? And what is the best choice of exercise for someone with kidney disease?
Well, I think number one, I'll start with the last question. I think that any exercise with kidney disease is important. Just move. I mean, even if you count your steps, I mean, any activity, from walking to bicycling to swimming, there is no activity which is with diabetic kidney disease, which would be adverse. I think, you don't have to overdo it. Don't exhaust yourself. I think use your judgment. Initially, just don't get injured by doing too much too quickly. Just start moving and doing any type, walking, swimming, stationary cycle, whatever it takes to move. That's point number one. And the other part of the question is that the muscle does not, exercise is not harmful to the kidneys unless you run a marathon where your muscles get damaged and you have what's called rhabdomyolysis, where the muscle cells burst, and then creatinine or substance from the muscle floods the kidneys and may damage the kidneys. But regular exercise has no damage whatsoever at all for the kidney, including weightlifting.
That's good to know. So someone else asked, are there any foods or supplements that help delay kidney decline in diabetic patients?
No, I think there are no really supplements to improve kidney function. I mean, there are dietary means to control abnormalities caused by kidney function. So if your phosphate is too high, or if you're anemic or you're iron deficient because of the kidney, so this would be late findings, already late complications with less than 40% of kidney function. But per se, supplementations like or vitamins good for the kidney is anything special you would use over the counter beneficial to the kidney. The answer is no.
That's great advice. So someone else asked, if someone has proteinuria or albuminuria, do you recommend a lower amount of protein, even less than 0.8 grams per kilogram per day?
Yeah, that has been done in the past. We don't want to do this anymore because unless you lose huge quantities. Now, if people lose 8, 9, 10,000 milligrams, which is like 10 grams, and 30 or higher is abnormal, then you may increase the albumin and protein intake. But normally, if you go below 0.8, then you are potentially at risk to burning your muscles as a source of protein. So a very low protein diet leads to malnutrition. It leads to loss of muscle. It makes you less likely to be able to get out of a chair or exercise, and you then also become a risk for infections, and so that's a bad idea. So somewhere around 0.75, 0.7, 0.8. One doesn't have to do this every day. I just want you to know roughly how much protein you take in. So 0.8 is probably the ideal number.
Thank you so much for that explanation. So someone else asked, since we talked about weight loss surgery a little bit earlier, since weight loss surgery can be used sort of as a prevention method, as a method to help control the weight for people with diabetes, can it actually be used to prevent diabetes?
Well, okay. Now, I'm not a obesity specialist, but I can tell you that if you have pre-diabetes and you're obese, and right now the indications for any bariatric or weight loss surgery usually covered by insurance. You got to be 35 BMI or higher. It also depends what other diseases you have with it. So let's just say you have pre-diabetes. We know that people with diabetes have been 5 or 7 years out, reverted to normal, have come up off all their diabetic medications, and many of them their blood pressure medications. So the answer is yes, pre-diabetes and diabetes has been reduced back to normal or normalized with bariatric surgery, people using 50, 60, 70, 80 pounds of weight. There are some studies where after 6 or 7 years, some of them the diabetes has come back. But again, in most of them, it has stayed away for these 5, 7 years. And we need more data to see in how many people after 10 years it comes back. Now, until the last 2, 3 years, we didn't know about kidney disease. So people with diabetic kidney disease and diabetes who had undergone bariatric surgery, we now have data in the last 2 years showing very favorable things. Number one, the albuminuria is naturally reduced by bariatric surgery, and we have seen a slowdown of loss of function, and in some instances, no loss of function with losing 50, 70, 70 pounds. So right now, the renal aspects of albumin and loss of renal function with diabetic kidney disease in bariatric surgery look very, very, very good. So if you would have a BMI of 38 and see me and we continue to lose renal weight, kidney function, EGFR keeps going down and your albumin cannot be controlled with any of the drugs I have, you and I would potentially sit down and have a discussion about bariatric surgery. So it does become, for these BMIs above 35, in very individualized patient who needs to have a real decision that's not for everybody to consider bariatric surgery. So renal-wise, the data are beginning to look very good.
Wow, that's really interesting. Thanks for sharing. So someone else asked, when you have a patient on an ACE inhibitor or ARB, do you prescribe a potassium binder if their potassium goes up?
That's an excellent question. I think that right now we don't like potassiums to go much above 5. So, if yours is 4.9 or 5 or 5.1, I'm happy with the ACE inhibitor. If it gets to be 5.4, 5.5, 5.3, and you recheck it once or twice, then you become a little bit, as a physician, concerned about the potassium because of arrhythmias with the heart and other issues. So at that point, we would first review your diet. So I don't want you to drink orange juice. I want you to eat the oranges because it takes 10 oranges to make 1 quart of orange juice. You're not going to eat 10 oranges. So the juices, and look at the diet, you may be taking in some foods. For example, let me give you the number one source of high potassium is artificial salt. Artificial salt is 100% 100% potassium. So you can get a high potassium just because you use artificial salt. So stop the artificial salt, start drinking juices, eat the fruit. If that doesn't do it, I think then one needs to consider reducing the dose, like you questioned. Let's say you're on lisinopril 40, you go from 40 to 20. If you cannot do this because your heart or your kidneys really need the bigger doses, there are now 2 drugs approved by the FDA, which bind potassium, and it's not the Kxalate, the terrible stuff you have to take with a laxative, which is very hard to take. So there are 2 drugs on the market. Again, they're expensive, but they are covered. But I think the options are, hopefully we can control it by modifying your diet. If not, the second option is to potentially reduce the dose of your ACE or ARB by half. And if that doesn't work, one may have to use a potassium binder, the 2 new ones on the market.
Thank you for that explanation. So someone else has a question about GFR and specifically asks, is it possible to improve GFR, for example, from 50 to 60? And if so, how?
Well, if your GFR was done, that's something very good question. I need to point out to you that an EGFR should not be done when you're not well. So let's say an EGFR in the hospital, an EGFR when you are having a procedure, colonoscopy, outpatient surgery, or get admitted to the hospital for whatever reason, is not a good way to judge your EGFR. Also, if you, let's just say, take a diuretic, and many patients now take diuretics only 3 times a week because that's all they need for their blood pressure in controlling their fluid retention, and many don't need daily ones. If you do it the day after you took the diuretic, your EGFR may be 55, and then a day later it may be 60. So the test goes up and down by 3-4 points, so it's not that accurate. So a 55 can be a 58. And if you're a little bit dehydrated, a 55 can turn into a 62 or 65. So the question is excellent. You like to see a couple of them done about a month or 2 or 3 apart. And you also like to make sure you're well and you're not dehydrated. So these are important issues.
Thank you for that answer. So we have another question here that says, could you please explain if and how water intake affects kidney disease? Can it help to improve kidney function?
Yeah, we had this motion there because it started with people thinking that if they drink 2 liters, 2 quarts plus extra fluid a day, and then they piddle every hour, an hour and a half, that they improve their weight, their appetite, which we know hasn't worked because obesity hasn't improved in this country. About 42% of all Americans are overweight or obese, and about 82% of all people with diabetes are overweight or obese. So this hasn't worked. And then the notion that drinking large quantities, there are only 2 conditions from the kidney which it's important to drink extra fluids. Let's say an extra 2 quarts or so a day. That's if you have kidney stones, okay, or you have polycystic kidney disease. So to go back to diabetic kidney disease, which is our topic today, is it will not help you. You're just going to piddle literally every hour, and you may wash out your vitamins. People don't know that vitamins some of them are water soluble. So like, vitamin the B's and folic acids and other things, you wash them out. And if you drink too much, you also wash out some of your salt. So your salt in your blood can go down. So the answer is no. Excessive fluid intake above normal hydration is not a good idea. Okay.
That's really good to know. So we have another question. This has been asked a couple times. So a popular question here about the keto diet. So someone asked,
Yep.
I'm thinking about starting the ketogenic diet. Is that safe for someone with kidney disease? Can it help to prevent diabetic kidney disease?
Well, I tell you what, the keto diet is number one. Please don't ever use the keto diet if you are on an SGLT2 inhibitor. So the empagliflozin, dapagliflozin, and anything with the gliflozin. So the SGLT2 inhibitors are very dangerous to take with keto diet. So if you're on a keto diet and the doctor gives you an estrogen inhibitor, stop the keto diet first. Okay, so that's number one. Number two, if you have kidney function above, let's say EGFR is above 50, or your EGFR is 75 and you have albuminuria, the keto diet, if it helps you lose weight and you're not on estrogen inhibitors, and that what works for you, fine. But if your EGFR drops below 50, the keto diet may also produce more acid, and then you have more acid retention from the kidney. So if you're close to 50, 55, and 60 or higher, you may again, that's not lifetime. You may go 2-3 months on the keto diet, provided you're not on SGLT2 inhibitors. But otherwise, the keto diet does not help you unless you lose weight. It does not prevent diabetic kidney disease per se.
That's great to know. Thank you. And rounding out our Q&A portion, here's our last question. Someone asked, can you repeat the 3 key lab numbers that we should know?
Okay. So as a diabetic, I want you to know, I want you to know your A1C. So and write it down. When you go to the doctor's office, you got all those numbers and you're rushed, the doctor's rushed away. So write down your A1C. Okay, it should be 7 or lower, and if you have diabetic kidney disease, 6.5 or less, provided you don't develop low blood sugar with the treatments. Second, know your EGFR, and that stands for kidney function, glomerular filtration rate. So it's EGFR. Know the number, okay, and write it down, and ask what your urine albumin is. So if your urine albumin is 30 or higher, or your EGFR is less than 60, you have diabetic kidney disease, and you should be aggressively treated with, an ACE inhibitor or an ARB, and with an SGLT2 inhibitor. So these are important. In addition, what your doctor wants you to know anyway, it's your blood pressure. Write it down, and what your cholesterol and triglyceride and the LDL is. But being a nephrologist, I want you to know your A1C, your EGFR, and your urine albumin, and that will lead to better care. And you know what you're doing. You follow the diet. You lose the weight. You see improvement in those numbers, and I think that is important. You should not be kept in the dark, and have the physician be the only one who knows those numbers.
Wonderful. That's so good to know. Well, thank you once again, Dr. Mende, for those great explanations. And this concludes today's webinar. This webinar was recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. We will have more webinars in the future. Please visit kidneyfund.org/webinars for more information and to register. When the webinar ends, please do not close your browser window. Your browser window should open a new tab to a webinar satisfaction survey. We ask that you please complete the survey. Your honest feedback will help us make our webinar program the best it can be. Thank you for joining, and we hope to see you again.
Again, thank you very much for listening. It was a pleasure to talk to you. Have a good afternoon. Thank you.